Hi, everyone. Welcome to today's webinar hosted by Hep United and the World Hepatitis Alliance. My name is Kate Morales. I am the Deputy Director of Public Health at the Hepatitis B Foundation and Director of Hep United. I'm joined by my colleague here and co-moderator, Jessica Hicks, who's Head of Programs at the World Hepatitis Alliance. Next slide, please. Hep United is a national coalition dedicated to reducing the health disparities associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities across the United States. We serve as a forum for sharing information and best practices and improving national capacity to improve hepatitis B awareness, testing, vaccination, and treatment among highly affected communities. And I'll turn it over to my colleague, Jessica, to share some information about the World Hepatitis Alliance.
Thanks, Kate. I'm so pleased to be here today co-hosting this webinar with Hep United and Hep B Foundation on behalf of the World Hepatitis Alliance. So the World Hepatitis Alliance is a patient-led and patient-driven not-for-profit organization. We have over 300 members in 100 countries, and together with them, we partner with national governments and other stakeholders to raise awareness, influence policy, and drive action to improve the lives of the 325 million people globally that are living with viral hepatitis. So in today's webinar, we're going to be focusing on the global impact of COVID-19 pandemic on hepatitis B prevention and treatment services. Our panelists today are going to discuss the short and possible long-term impacts that the pandemic has had on hepatitis B initiatives, including disruptions to prevention, diagnosis, and treatment services, and the impacts the lives of those living with hepatitis B and the potential of that to threaten the global hepatitis B elimination goals. Importantly, speakers are also going to share local experiences and recommendations on strategies to mitigate the impact of the COVID-19 pandemic. And before we hand over to our speakers, I'm just going to pass back to Kate for some housekeeping.
Great, thanks so much, Jessica. Before we get started, I'd just like to remind everyone how to participate during today's webinar. All attendees are in listen-only mode. If you encounter technical difficulties online with your computer audio, please dial in using the phone option on your control panel, and the conference line will be shown in the audio tab. At any time during the presentation, you can enter questions into the question box. We will be addressing the questions at the conclusion of all of the presentations. And also, if you have any technical challenges, please feel free to indicate your issue using the question box as well. All right, so I'm going to just go ahead and introduce our first speakers on the next slide. Our first speakers are Dr. Philippa Matthews and Ms. Caitlin Play. Dr. Matthews is a consultant in clinical infection and an associate professor at Oxford University. Her group works on understanding different outcomes of chronic hepatitis B infection, with a special interest in African populations. And she has close partnerships with clinical and research groups in South Africa and Uganda. And following Dr. Matthews is Caitlin Play. Caitlin is a final year medical student at the University of Cambridge with a range of experience in infectious diseases and global public health. She recently spent a year working as a strategy and policy analyst with the Global Fund to fight AIDS, TB, and malaria, where her focus areas included climate change, fragile and conflict contexts, and mitigating the impact of COVID-19 on Global Fund programs. She also works with Dr. Matthews and her team at Oxford to conduct research on hepatitis B, as well as working with the World Health Organization's Global Health Workforce Network Youth Hub. And without further ado, I'd like to go ahead and turn it over to Dr. Matthews.
Thank you so much, Kate and Jessica, for the introductions and the background. It's a great pleasure to talk on this topic and to be part of the process and the discussions today. So thank you for the invitation, and thanks everyone for dialing in. I'm sorry my webcam doesn't work, so you can't see me, but it's nice to be virtually connected anyway. So the background to this invitation for us to talk to the meeting was a piece of work that Caitlin actually led on gathering the data, and myself and colleagues at the University of Oxford were involved looking at the impact of COVID-19 on the prevention, diagnosis and treatment of hepatitis B. as Kate's indicated, hepatitis B is my primary research and clinical interest pre-COVID. I've also been very much sucked into COVID activity in Oxford, both clinical and research over the last year. So I have some sort of understanding of the situation, I guess, from both sides of the fence, clinical and research, and thinking about COVID and thinking about hepatitis B. And of course, we're in just an unprecedented situation over the last year. And there are major challenges associated both with managing the ongoing pandemic situation, but also with kind of realizing and trying to negate some of the impact on other neglected public health problems, of which hepatitis B is obviously one. So next slide, please. So I'm sure those of you who are joining this meeting are very familiar with the kind of global epidemiology of viral hepatitis, but just to sort of reinforce the scale and the burden of hepatitis B in particular, with cases that far outweigh either HIV or Hep C, but kind of advocacy and infrastructure and funding that's way behind those other bloodborne virus infections. So we start from a kind of neglected standpoint. Thanks. If you could advance to the next stage. Thank you. So again, as you know, I'm sure we work in the context of these sustainable development goals set out for the international community to combat viral hepatitis, with a very clear set of targets that have been set for 2030. And of course, those have already been very ambitious even before COVID arrived on the scene, and are now feeling even further out of reach. But with the specific mandates enshrined in this global health sector document, setting out in particular a target for 65% reduction in mortality by the year 2030. Thanks. Next slide, please. So in terms of challenges, I always talk about the tip of the iceberg, which is a bit of a cliche, and colleagues in Africa told me I should talk about the tip of the hippo, which kind of gives you a similar 10% view of what might be poking up above the surface. But worldwide, there are 360 million people infected with viral hepatitis, of which only a very small minority, perhaps 10 to 12%, are aware of their diagnosis. And then it's the tip of many icebergs, really, isn't it? Because very few proportionally of them are actually able to access and take regular treatment. And we live in this kind of era where so many cancers are actually falling due to better diagnosis, better intervention, better treatment. But actually hepatocellular carcinoma is bucking that trend and is on the increase. And is one of the reasons why hepatitis B infection still causes so many annual deaths. And one death every 20 seconds is startling, isn't it? And we live in an era where we've got used to statistics on viral deaths being headlines every day. But of course, hepatitis B has been doing this for centuries before COVID appeared, but really without any particular impact in terms of a kind of awareness and advocacy. So my group wrote this paper actually in 2017 that was published in Neglected Tropical Diseases, representing hepatitis B as a neglected tropical disease. Of course, there's nothing about it that means it has to be focused in the tropics, but so much of the world's burden is there. And of course, the infrastructure and funding tends to be limited in many tropical countries, which means that the vast burden of the morbidity and mortality of this does fall in tropical regions. And we deal with all sorts of barriers to elimination, not exhaustively listed here, but you'll be familiar with these many problems that existed even before COVID arrived on the scene. So that gives a bit of context to some of the challenges and the burden of disease. I was hoping to turn over to Caitlin to take this forward, but I think she hasn't managed to join the call. So I'll just keep going. So if we could go on to the next slide. Thank you. So there's some data that's been gathered and collated by the World Health Organization looking at the proportion of countries that have reported at least partial disruption due to COVID. And I mean, this doesn't come as a surprise, does it? But it sort of gives us some idea of quantifying the level of disruption, with nearly a quarter of the countries worldwide reporting disruption of at least 75% of their services. So massive blow to routine service delivery. And of course, in low and middle income countries, that burden of disruption is proportionately higher. And then if we look at the kind of economic costs to this, in America thought to be over the $50 billion mark. And again, in low and middle income countries, that takes a proportionately greater hit on already very constrained healthcare budgets, and poorer countries will feel the most impact of economic contraction. So vast implications for ongoing service delivery. Thanks. Next slide, please. So when we set out to do this piece of work to collate evidence for the kind of disruption that COVID might be causing, of course, there's a limited amount of quantitative data available, and more being gathered as time goes on. But there are these various categories that we've considered to assess the burden and the extent of the disruption, from vaccination campaigns, the impact potentially on transmission, the impact on diagnosis, access to treatment, the impact that's felt as a result of health inequalities. And then what we tried to do is come up with a series of recommendations for areas where practical action can be taken. And of course, that's very difficult when I've already set the scene by saying the impact of the financial situation. But at least it kind of puts some stakes in the ground for areas that we can try to focus on as time goes forward. Next slide, please. So the starting point is, of course, difficult to collate data for hepatitis B vaccines in particular. But what we did is we looked back at historical data showing the potential disruption to vaccination campaigns that have been the result of a variety of disruptions to society relating to political situations, social unrest, war, and so on. And what you can see quite consistently in these plots is the dip that you have in vaccine coverage, shown in the white line in each case, when there's a disruption to society. And it's very consistent, more striking in some instances than others. So that while the world's progress shown in the blue line on vaccination is going steadily up, or at least is stable, you see these kind of huge dip in vaccination campaigns. And of course, for hepatitis B, we might not see the consequences of that immediately, but there'll be a very significant potential consequence in terms of a generation missing out on hepatitis B vaccination due to this kind of hit. And of course, in this situation, it's not just limited to one country suffering social disruption, but an international situation. Thanks. Next slide, please. So in terms of hepatitis B transmission, it's interesting thinking about how a pandemic might influence that. And actually, the lockdown circumstances may mean that transmission has reduced, but there are also a whole host of factors that may mean that transmission increases. And again, this is not based on data that you can gather in a quantitative way, but it's based on an understanding of the likely impact of societal and healthcare disruption. So just going around these points briefly, obviously harm reduction services already often scarce and minoritized, for instance, people who inject drugs. These kind of programs hugely interrupted as a result of the pandemic. Access to antiviral treatment. We can think about treatment obviously as being of a benefit to the individual who's taking the treatment, but of course it also has a public health benefit in reducing onward transmission. And actually, it's a key advocacy point of mine to say that we ought to be using hepatitis B treatment in a way that is thought of for HIV, which is treatment for prevention, right? Treatment prevents disease in the individual, but it also prevents ongoing transmission at community level. And so there is a public health aspect to interrupted supply of antiviral drugs. Risk behaviours, I alluded to the fact that transmission may actually have decreased because of reduced contact and social distancing and so on. But of course, there may be also adverse increases in risk behaviours, for instance, drug and alcohol misuse, which are difficult to measure, but we may see spin-off consequences in bloodborne virus infections. Home births, I've been interested in thinking about prevention of mother-to-child transmission in South Africa, where a lot of my clinical cohort work is based. And of course, getting birth dose vaccine into babies is very strongly dependent on having at least a trained healthcare professional present at the birth. And the impact of the pandemic will doubtless have been that more births are at home and more births are not attended by a trained healthcare professional of any kind. And so getting birth dose vaccine delivered into infants is undoubtedly going to have been interrupted. And then likewise, ongoing care of infants through antenatal care programs will be reduced, and so getting secure 3-dose regimens into infants is also likely to have been impacted. Thanks. Next slide, please. So thinking about diagnostics, we know that that diagnostics is going to be key and needs to be really scaled up if we're going to come anywhere close to meeting these international targets for harm reduction by 2030. And of course, diagnostic programs are often run opportunistically, maybe targeting high-risk groups, maybe targeting attenders to emergency departments, maybe targeting a community-level screening programs, all of which will have been interrupted by the pandemic. And this will also have a long-term impact on transmission dynamics, as I've indicated, because we then don't get people onto treatment and we don't rein in viral loads in people who are most at risk of transmission. Diversion of funding, infrastructure and human resources, of course, impacts on our ability to deliver diagnosis. And it may just be that diagnostic supply chains get interfered with. Any of you who've been working in clinical and lab facilities over the course of the pandemic will know that even the supplies of very simple plasticware, pipette tips and so on have all been significantly impacted as a consequence. And so this certainly interrupts capacity to do even basic surface antigen testing potentially, but also the allied e-antigen testing, viral loads and so on that we need to provide a good standard of clinical care. And then of course people may be less willing to attend healthcare facilities or less able to, either because there are formal restrictions or in fact because people have become afraid of attending healthcare facilities for risk of being exposed to infection. And I think the data plotted on the bottom right of this slide are quite striking, aren't they, in terms of new patients being reviewed in viral hepatitis clinics. If you look at that drop off in numbers for 3 select countries where we do have data, they're down by at least 70% and in some cases 95% reduction in new patients being reviewed. So very, very striking impact from which it may be quite hard to recover. Thanks. Next slide, please. So then thinking about reduced access to treatment, we've talked about fear of health facilities and stay-at-home orders, which mean that people may not be continuing to access and take antiviral therapy. Of course, if resources are impacted and individuals are having to purchase medicines out of pocket, there's an implication on an individual level that that people will find it harder to pay. People's financial circumstances on an individual basis have obviously been potentially profoundly impacted by the pandemic, but also at a societal level where resources are being diverted to other priorities. And within the health system, healthcare workers are being redeployed to other areas. I've certainly experienced that at first hand in Oxford. So we've, for instance, lost our FibroScan facility during the pandemic because our nurses have been redeployed to work in COVID-facing clinics. In some cases, health facilities have closed altogether. Supply chains have been disrupted for medications. And while some of us are lucky and have been in environments where telemedicine has been able to scale up so that we've retained at least a point of contact with patients remotely, this is evidently not practical or deliverable for many of our patients globally with hepatitis B infection. And I think these data from Italy at the bottom of this slide are really striking, aren't they, in terms of the actual hard impact of what's been felt for patients with hepatitis infection. 1 in 4 hepatology wards converted for COVID care. Again, in Oxford, this has been our experience. Our hepatitis unit was indeed closed and moved onto another site, but with very limited bed spaces. A quarter of drug treatments postponed. Even for patients with hepatocellular carcinoma, where we know survival rates are so poor because of late diagnosis, less than 20% continuity of care. So that has a major impact on mortality. And for decompensated cirrhosis, again, another very vulnerable patient group, very poor continuity of care. And this is in a European centre where they've been able to collect and measure and quantify these data. But of course, that's been impossible in many parts of the world, which are dealing with the highest burden of viral hepatitis. And the communities where I'm involved in, South Africa, typically between 5 and 10% of adults have chronic hepatitis B infection. So the impact on services in those communities is even greater. Thanks. Next slide, please. And it's very interesting the way that this pandemic has amplified health inequalities. And I think this has been said in a whole variety of fora, which range from economic recession and poverty, both on an individual basis, but also the impact on whole, local and national economies. The fact that people face unemployment and that may have an impact on their health insurance. The fact that there are other comorbid non-communicable diseases. I've got an interest in looking at the impact of diabetes and other metabolic disease on the outcomes of hepatitis B. And of course, chronic renal disease is also very relevant in terms of potential outcomes and the impact of treatment and so on. And so the impact of viral hepatitis is not just through hepatology services, but through a far wider range of non-communicable disease treatment. And of course, communities that are already disadvantaged, minoritized, may be hard to reach through conventional healthcare channels, are hit even harder by the contraction of services. And there's all sorts of data emerging on the inequity that the pandemic's imposed on women and girls, which ranges from education through to opportunities, through to provision of healthcare, and indeed impacting all of us in many ways in terms of sort of academic and career opportunities as well. So very diverse data already emerging in this space. But of course, for care of viral hepatitis and prevention of mother-to-child transmission programs and pediatric health and infant vaccination, being able to access your women of childbearing age is so key. And so impacts on those groups may have a disproportionate impact on what we see in terms of the impact on viral hepatitis. Thanks. Next slide, please. So to summarize what we've tried to pull together in this article, I should say that the citation for the article has been on the bottom of each of these slides, and it's there on the bottom of the slide that I'm presenting now. So if you want the citation or the DOI, there it is at the bottom. What we've pulled together here is just a summary, really, that suggests all of these different domains in which the pandemic has had an influence. So interrupting vaccination schedules, having an influence on transmission. We don't know whether that is a positive or a negative influence, and probably a bit of both. Certainly having an influence on access to diagnostics and diagnostic testing, and similarly having a significant impact on treatment and antivirals, and indeed with the potential for reactivation of cases as a result of those interruptions. Thanks. Next slide, please. So as I indicated at the beginning, it's kind of important to think about this in terms of how we actually go forward. So we've tried to make some practical recommendations, acknowledging that these are far from easy. There are lots of challenges involved in doing this, but collecting data is very important. And I would encourage any of you who are in a position to be able to do this to think about how you might actively do this to identify gaps in services and feed a response. Thinking about scaling up service provision, so improving infrastructures for telemedicine, better use of electronic patient data, and obviously there's been a huge amount of improvements in how we can social distance and provide safe facilities for patients and our staff. Political buy-in, I'm sure you're on the same page as me, so I don't need to preach to the converted, but trying to develop better strategies that get advocacy and a political platform for hepatitis B intervention. And thinking about financial schemes, so how can we support our patients to diagnosis and treatment? Thanks. Next slide, please. We may be looking at needing to provide catch-up vaccination for infants who've missed out, not only, of course, on hepatitis B vaccine, but on the whole infant and early life vaccination regimens. Public health interventions are going to be required to audit interventions and distribution of care. We need better education and public health messaging to make sure that people feel safe and that they understand the benefits of care seeking. Obviously, there's going to be a lot of advocacy around COVID vaccination, and we've got an opportunity there to build in positive messages about vaccination for other conditions as well. And supporting advocacy, I think, is so important for hepatitis B. And obviously, this call has been arranged really as part of that work of generating advocacy, but trying to support that in our communities and through charitable work as well. Next slide, please. So that takes us on to Arafat next. So just to say again, thank you very much for your attendance and for your interest in this subject. It's been a pleasure to talk to you all, and I think questions will be collated and shared at the end. So I'll hand back there to the organisers. Thank you.
Thank you, Philippa. And as she said, please do continue to put your questions into the questions section on the platform, and we will get through everyone's questions after Arafat's presentation. And so again, so thank you to Philippa. I think that was a really great overview, and I think it's quite fitting that one of your last points was on the importance of advocacy and support for advocacy groups. We firmly believe that we will not reach elimination without putting civil society and the affected community at the heart of the response. And Philippa touched on many of the barriers to accessing services that COVID has created, but we have seen the impact that civil society can have in overcoming these. And our next speaker is expertly placed to speak to this. Arafat Bouambali is the head of Health and Policy Program Manager with Great Lakes Peace Centre, which is a youth-led grassroots organisation, and he works there with a team of vibrant young people and women to support social justice and advocate for good health for all people, livelihood in farming, governance and democracy. Arafat also works with the Bouera General Hospital as Medical Clinical Officer and Public Health Officer, and has served as a patient advocate for hepatitis B and a hepatitis champion. Before we hear from Arafat, we are going to share a short video highlighting the work that he's been doing during the lockdown and the pandemic, and then he will further elaborate on some of the points raised in that video during his presentation.
Bouambali Arafat, work with the Great Lakes Peace Centre. It's a youth-led grassroots organization formed in Uganda. Basically, our thematic areas are health promotion, specifically trying to mobilize communities and empowering to be able to have access about the awareness, treatment, and care about viral hepatitis B and other infections. Specifically, on 17th of March last year, this is when the Republic of Uganda got into the lockdown. And some of us who have been working with Great Lakes Peace Centre, specifically, we work directly with Bouera General Hospital, where we have a committee of people who live with viral hepatitis. And they have their chairperson, they have their secretary, they have their coordinators. So these people always come for the refills at the hospital, and there are about 250 patients who do a refill for on treatment. So on 17th, when the Republic of Uganda went into the lockdown, completely there was no means of transport, there was no movement. Commonly people here use borders as motorcycle. And of course, the hospital is in the center in the region, neighbor at the footstep of Rwenzori Mountain. And most of the people who suffer from viral hepatitis stay about more than 5 kilometers, 10 kilometers, and the hospital serves about 3 districts, Luberizi, Kabarole, and Kasese. So there's a vast number of patients who always come to the hospital to get the refill. So through the lockdown, the restrictions were not relaxed. People are not able to move. But remember that patients are supposed to come and get their refills from the hospital. So what we decided under the stewardship of Great Lakes Peace Center and myself, we had to profile young people who are in holidays, who are from the universities, and most of these young people work with us as volunteers. And sometimes we call them the hepatitis champions. So what exactly was that health workers are not able to move, the patients are not able to move, the community members are not able to move. So that was a big problem because the patients were unable to come for their appointments, they miss out on their appointments, the pregnant mothers will not come for testing, and these people are coming from distant places. So what we did is that we constituted ourselves into 5 group of volunteers, 3 girls and 2 gentlemen, whom what we would do is we would work on phone. We had to get a phone, and we were calling the chairperson in charge of people living with viral hepatitis within our area. And we were able to profile those who badly needed, had made some missed appointments, and those who are living at distant point. So each day would be able to profile like 10, 20 patients who would need to be delivered their medicines. So we would ask our friends within our area or the villages or community members whom we work with to be able to, for instance, to help us with motorcycles or bicycles, because what was there is that most of the people had missed out on coming for their investigations. The people had missed out on coming for their refills in terms of getting their medication. So in the first 2-3 months, what we did is that we'd be able to identify a certain patient who lives in a distant place, about 10 kilometers away, and then those who are not able and they are weak, those who have liver cirrhosis, those who have complications, we profile them, have a phone call with them. We had to walk on foot to go there and see their homestead, because from their chats at the hospital, we accessed the hospital chats through their chairpersons or through their committee, which would say patient Y, Z, X are the people having failure to come to the hospital. So because we were having a challenge of transport, and we are young people who are energetic, we can be able to walk long distances to ensure that we are able to deliver these medicines. So we'll be able to know patient X, his appointment has come in, he's on this kind of treatment, walk on foot. If that place is near, like about 5 kilometers, we go in there and tell them that it's very, very important to come for their refills. And also it's very, very important for us to give them their medicines, and then also to share with them how important the appointment is. So there are some other patients who live far beyond into the mountains, where we'll be able to borrow some motorcycles from friends, and they would give us like 1 motorcycle or 2. You walk on foot, you ride the motorcycle there, or use sports bike. These bicycles where you'd also ride to reach there and you'll be able to deliver the medicine to these people. But also importantly, as we went on delivering these services, of course, I can't hide that we were overwhelmed by the numbers, because most of the patients were not able to move from their places. We health workers also, by that time, we don't have personal protective gears. So, but as young people, we had to say, no, I think we are born from here. Most of the patients, we know them. It's very important for us to move up to their areas and be able, 1, to ensure that we refill for them their medicines, 2, continue offering our services in terms of counseling and health education. And then also importantly, most of these patients did not know about the new enemy with whom we had been confronted with, especially the COVID-19 pandemic. So that's exactly how we went about our business, and that's how we felt that the biggest challenge which was confronting us as the CSO. We felt that those are some of the mitigating measures which we put in place there. However, there are broad challenges which all of us, both from the health workers, both from the CSO organizations, both also the patients, they go through. Most of the patients, we realized that most of them suffer from catastrophic expenditure, like out of pocket, because most of the investigations, most of the travels as patients, most of the investigations like viral load, complete blood count, liver function test, all these ones are out of pocket. The patient spends on them. So under COVID-19, the challenge was, if people are not having food, If people are not able to walk, how can they get money to come and be investigated at the hospital? So one of the challenges which we're grappling with as CSO, which has been helping, which has been raising awareness, encouraging screening, encouraging vaccination, encouraging testing at outreach points and at the hospital. One of the challenges when we interact with the patient was out of pocket, which I characterize as catastrophic expenditure, because most of these investigations are billed in healthy facilities, and also some of the public facilities also bill them. Then the other thing which we really grappled with, which I talked about, was the lack of means of transport. Look, COVID-19 came on 17th. Uganda went under lockdown on 17th, and our index case was on 21st. So we are not able to move. We don't have means of transport as CSOs. Also, the patients didn't have means of transport. So Great Lakes Peace Center, at the moment, we didn't have a means of transport. That's why we do now call out people in our community maybe to help us with a motorcycle or bicycle to ride, or sometimes where we see the situation is not, we're not getting solutions, we would just walk on foot up the mountains there. Then the other challenge we faced, of course, there was health inequality through poor attendance of OPD. There was a myth which was going through during the COVID-19 that once you come to hospital to seek medical services, then you are also going to suffer from COVID-19. So most of the patients, from the CSO perspective, did not go to seek for these services from the health facilities. And definitely because of these health inequalities, they were exacerbated by disruption of the assessment, the linkage, the testing, the vaccination, both at static and at the outreaches, because we had to stop all these taking place because we're under restriction. The restrictions were not relaxed, and we are not able to go there and see the patients. So this reduced access to treatment, increased the number of missed opportunity in terms of refill and investigation. The other challenge which was there is that, like I had already alluded to the fact that there was some information which was circulating within the community that once you suffer from hepatitis B, then it is easier for you to contract COVID-19. So most of the pregnant mothers, who are some of the patients who are well known to us, were not able to come to the facility because of that challenge. So failure of pregnant mothers to come for ANC. And you know for sure that if mothers do not come for testing and screening during the antenatal care, then we are going to reverse our efforts in terms of the prevention of mother-to-child transmission. The other challenge which we faced during the pandemic, both the patients, health workers, was lack of education and public message. Because the message which was there now came and surpassed the efforts we are putting in there. So the hepatitis B information was not surfacing anywhere, but rather much of the information was all about COVID. So those are some of the challenges that we are facing. The other challenge which we faced, both from the patient perspective, was stigma and discrimination. Indeed, most of the community members would not be able to support the patients who are suffering from viral hepatitis to come and be at the health facilities where we would be able to screen them, to assess them medically, to get their services. So that was one of the challenges. And then unfortunately, in the employment force, these people were discriminated. These people are being stigmatized during the pandemic. And the numbers had to increase. And also because of stigma and discrimination, we're also experiencing gender-based violence among the community members. So some of these were the challenges that we're grappling with. The other challenge which we faced was the lack of advocacy in terms of support. Because now, look, the CS, all of us, we had to slow down our activities, and the gap of advocacy in terms of supporting awareness efforts was reduced during that time. So those are some of the challenges which we continue to grapple with. The other challenge which we also faced so much during the COVID-19, especially we as the CSOs and also the community members and the patients themselves, is that we still grapple with the challenge of scanty data about viral hepatitis. Some of these data, the contacts of these patients, where they stay, the address, it was very scanty, because now we worked with the committee of people living with viral hepatitis within our community at the hospital arrangement, but some of the data is not there. We don't know who are suffering from, because after we had interacted with those few patients, we wanted to extend our efforts to other people. The other challenge which also we faced during our health service delivery, specifically viral hepatitis, is the myth about viral hepatitis. People think, traditionally here in Africa, most people think that viral hepatitis is associated with witchcraft and someone being bewitched. So some community members, when we go and tell them to support some of these patients, they would still say that maybe it was witchcraft which was there. Then the other thing which as a challenge we faced is that the challenge of the geographical area. Like I had already alluded to the fact that Great Lakes Peace Center, we operate within the foothill of Mount Rwenzori. It means our topography is mountainous area. And now us as health workers, us as the CSO, climbing up the mountain was very difficult. The other challenge which we faced here during the COVID-19 was the outside birth, which was being conducted by traditional birth attendants during the COVID-19, because the pregnant mothers had been used to come to deliver from the hospital, but now this time round, these people are not be able to come to the hospital. So the traditional birth attendants are still within our communities, and this puts risk to the patients, both to the traditional attendants and also the pregnant mothers, because if they deliver outside the health facility, the children born are not able to get the birth dose, they're not able to be vaccinated, they're not able to be screened. So the other thing which was also very challenging both the patients was the issue of nutritional support, because if the patients are there, they need to continue gardening, they need to continue getting nutritious foods, but this was restricted. The patients were not able to access them. So, and if you looked at the data, most of the health facilities, some of the patients whom we interacted with had issues with malnutrition, especially pregnant mothers who had children below 5 years. This was associated much to the lockdown, and some were not able to go to the gardens and cultivate crops, make nursery beds for their, for these vegetables, and this exacerbated malnutrition. And when you carefully look into the data, you find that most of the mothers who are living with viral hepatitis and are breastfeeding mothers, most of them came with children with malnutrition within our communities. So those are some of the many challenges which we faced. And then also lastly but not least was the challenge of the key messages of viral hepatitis. One, for them to be put in languages that we understand very well, because of the rural woman who holds a hoe. How can she be able to, to understand some of these key messages? So those are some of the challenges which we faced as a Great Lakes Peace Center, with the facilities which work with very closely to amplify and raise the awareness about viral hepatitis B. So those are some of the things which I vividly remember that we faced with, but also importantly, to say that I think it's high time we started also thinking outside the box as CSOs. How can we be able to mobilize resources? How can we be able to avoid these outside births? How can we be able to have vaccines availed? How do we again get out post-COVID? How do we be able to go out and carry out a screening of the very many people, the burden that we are suffering from? Those are the few challenges we faced from the time on 17th of March last year to the time when we started this in the month of April, because we were working with Vera General Hospital and other facilities, and then also the other CSOs within our community. I thank you very, very much for listening to me.
Thank you, Arafat, for that great presentation. And I think those questions you finished with are so important, and I certainly don't have the answers, but I can say that they're questions that we're looking at as well. And I know in terms of prevention of mother-to-child transmission, we're actually about to launch on the 6th of April a No Hep Mums and Dads campaign, which really looks around how can we make sure that women are more aware of the importance of hepatitis B testing and birth dose, and really puts a spotlight on some of those issues you were saying. So now if I can invite Caitlin, who's joined us, along with Philippa and Arafat, to put on their cameras. And we have received a couple of questions, and we do have some time, so I'm going to try and get through all of them. So firstly, question to Caitlin and Philippa. So on the slide on disrupted vaccination campaigns, was the hepatitis B vaccine coverage in respective countries reflecting children, or does it also include adults?
That's a very good question. I believe that data is the joint WHO-UNICEF data on vaccination, so it should include adults as well. But correct me, Philippa, please, if that's wrong.
Yeah, I think that's likely to be right.
Great, thank you. And a question for you, Arafat. Did you say that the belief in Uganda is that viral hepatitis is witchcraft? And if so, why?
Oh, yes, I think that is a wonderful question. It looks like from the community perspective, most of the people still insist and think that a viral hepatitis infection is generally caused by witchcraft or being beaten by a wizard. And this is very unfortunate, because if a community member is not be able to be screened and tested at the hospital, then how can you know that this is mere witchcraft? So we need to prove beyond reasonable doubt about scientific facts and mere myth. So that's something we continue grappling with within our community members. Like I earlier shared, that I work with a grassroots, typically rural CSO.
Well, thank you. And another question, or maybe it was posed to Caitlin and Philippa, but Arafat, do feel free to jump in on this as well. So during the 2015 Ebola outbreak in West Africa, we saw increases in teen pregnancies with social distancing, isolation, and quarantine. Do you think this could also be possible in COVID-19? People don't have other avenues for social connection. So do you think it's possible that we'll see increases in pregnancies as schools are closed, etc.?
I can see Arafat nodding. I mean, I think I don't have any data, but I would be nodding as well, unfortunately. I mean, I think there's very far-reaching consequences in terms of all sorts of reasons why young women potentially may be at particular risk in these kind of difficult times. So ranging from economic factors on their families, ranging from lack of education, ranging from breakdown of other support networks, ranging from lack of access to contraception and sexual health. I've done some work again pre-COVID looking at the effects of societal disruption on female and adolescent sexual health, and they're huge. So in times where society kind of breaks down for any reason, you do see, unfortunately, these very profound consequences on young women as a kind of marginalized group, but in fact sexual violence against young men as well. So unfortunately, I think that's highly likely, although I haven't seen any data to corroborate it. Arafat and Caitlin, you may wish to add to that.
Okay, thank you very much. Like my colleague had already alluded to the fact that viral hepatitis data is always very scanty. And you can't have your hands onto the data saying that some of these things are happening, but maybe through observation, what is happening is that most of the young girls during the relaxation of the COVID-19 restrictions is that they're at home and they are just out there. And for sure, I think there's an increased number of teen pregnancy among the community members, and then also exacerbated by sexual gender violence among the families. Like apparently people look like they're not into productive side in terms of being at school or farming. So more people, the teen, are just at home. And Uganda currently, we haven't relaxed, we haven't allowed the secondary schools to start on, where most of these teen girls are always. So these normal cases, especially some of us who are in the practicing in service, most of these cases keep coming at the hospital. And once you check with the medical form, you find some of these pregnancies are just related to the teen. Yes, I do agree that COVID-19 has been able to exacerbate early marriages and teen pregnancies. I do concur with that.
Thank you both. And I think this actually, we've received a comment that really links in with this as well, which is that it's a great deal to reach out to those in need, especially women and girls who are worst hit during this COVID-19 period, and that there should be a global intervention and consideration needs to be given to these hard to reach communities. And I think we would all agree with that. And, you know, as I said, we have our No Hep Mums campaign, which hopefully will start to shine a spotlight more on women and hepatitis B, but a lot more needs to be done. I'm not sure if any of our panelists would like to add to that comment.
I think another
Okay.
point that,
Yeah.
sorry, Philippa.
Caitlin, do you want to go ahead and then we'll jump to Philippa?
Absolutely. So great points raised by the other panelists. I think another thing that particularly affects women and girls is always a large burden of unpaid labor, which has only increased during the pandemic. So often women are the last to be able to access healthcare. And at the moment, with children often not going to school, and a lot of the burden of unpaid care work on women and girls has been raised severely. And with, at the same time, economic constriction, it often means that women and girls are the first to lose out on healthcare and education.
That's an excellent point. Philippa, did you want to add anything to that?
Only to endorse and underline what's been said, actually. So I mean, I'm really pleased to hear there's a specific campaign being directed from your side, Jessica, in this realm. I think, yeah, we covered in the presentation some of the reasons why women and girls might be adversely and disproportionately affected, and this is a really particular arena that needs careful focus. And of course, for prevention of mother to child transmission of hepatitis, you also need mothers to be engaged in care and able to access care. So it's I think it's a very good area for focus.
Great, thank you. Yeah, so hopefully I will be sharing more details of that when it launches on the 6th of April, and really do encourage everyone to get involved in that campaign. So I know that we are right on time. We do have 1 or 2 more questions, so we'll try and do those very quickly. So firstly, to Arafat, just a question around what is the prevalence of hepatitis B in Uganda, and has birth dose and childhood completion of the vaccination series been implemented there, and are susceptible adults being vaccinated against hepatitis B? There's a couple of questions in there, so I hope you got them all.
I'll just try to see what's just off my head, but what is important is that at the national level, we are talking about 5.8 to 6.8%, but these prevalence percentages vary from northern Uganda, western Uganda, central Uganda, and then different regions. They keep varying. But I think the most important thing, which I would also want to say with the authority, is the issue of the rural communities, specifically Kasese, where we are at 5.8 prevalence rate. But also importantly, what is very, as we know that viral hepatitis is preventable by vaccination, the data from the district authorities still indicate that vaccination, even the vaccination that has been provided by government, we are still grappling with the vaccination uptake of 0.8%. So the vaccines are available, but the rural communities are not able to come and pick up the vaccination. I think moving forward, what we need to do is to see how we amplify and cause awareness among the rural communities to be able to take up the service. The other important thing is that, unfortunately, as we want to deal with the prevention of mother-to-child transmission, birth dose is very, very important, but this has not taken root. But also importantly, I must applaud the government of Uganda that under its expanded program for immunization into the vaccines that are being rendered to. Way back 2002, we started the vaccination of children. So most of the children who are born above 2000 almost are vaccinated. But I think moving forward, we need to reinforce the efforts of vaccination by giving people birth dose. Unfortunately, in Uganda, we do not have that. But also, Jessica, the most important thing is that if we are able to amplify and raise the profile of awareness, we need to suck in the campaigns, the young people. These people have a lot of energy, they have enthusiasm, they're enthusiastic about the programs. And I think as young people in the Great Lakes Peace Centers, the CSOs,
we need to bring in as new energies to be able to advance this agenda. And I'm sure with the inclusion of young people, the elimination by 2030 can be possible.
Great, thank you. I think that's a great point. We definitely need a really strong advocacy voice for hepatitis, and young people are definitely a part of that. And now just the final question towards Caitlin and Philippa, just a question on why there is a discrepancy between WHO hepatitis figures and Polaris's hepatitis figures. I'm not sure if you can answer that question, but I'll put it to you.
Well, I think it's challenging because, as we've said, the data are very poor in terms of, you know, what we're looking at as a global hepatitis burden is based on largely estimated data, and we know that on a global platform. But I also know it from personal experience when I started out Hep B research in South Africa, and I asked a particular community at hospital where I was working if we could establish some hepatitis B work, and they said, well, sure, but we don't have any hepatitis B here. And the reason they didn't have any hepatitis B was, of course, because they weren't testing. And as soon as you start testing, you find, you know, 10, 11, 12% of antenatal women are hepatitis B positive. So that's a kind of anecdotal answer to which you know, scratches the surface of a kind of huge question about how we measure burden of disease. It's a really interesting question. I don't have a more sort of systematic or quantitative answer. I don't know if anyone else on the panel can give a better answer, but broadly speaking, I think it's because we're relying on modelled estimates, which have very wide confidence intervals around them.
Great, thank you. Caitlin, did you want to add anything to that?
I don't have anything more to say other than what Philippa has already said.
Great, thank you. So I think that's all our questions, and I know that we are just past time, so I will hand back to Kate, but thank you to everyone who submitted a question, and to all our panelists.
Great. Thank you so much, Jessica, and all of our panelists. Thank you to our speakers, Philippa, Caitlin, and Arafat, for taking the time to share your experiences and your research with us today. I think this really provides us with a lot of lessons learned and great policy recommendations for thinking about the sustainability of our infrastructure for future, God forbid, pandemics that we may experience. But we are much better prepared because of what you have shared with us today. And I wanted to also thank the World Hepatitis Alliance and Jessica and Katka for partnering on this very important webinar with us today. And thank you to our audience for joining, participating. We hope that you found the information valuable, informative to your work, and that you can apply some of this information moving forward. So before we close out, if you could go to the next slide. We encourage everyone to complete an evaluation form, which will be available as you exit the webinar. And this will be very helpful for us in thinking about future webinars moving forward and potential topics to share with everyone. And finally, please do feel free to reach out and get in touch with us using the contact information on the slide from the Hepatitis B Foundation and from the World Hepatitis Alliance. And visit our websites for more information and also future campaigns that Jessica mentioned. So thank you again for joining us today, and we hope that you have a wonderful rest of your day or evening. Great, thanks everyone. Talk to you later.
Thanks everyone.